You want to start the
Okay. I haven't heard you, sir.
Yeah, so this patient presented with trauma to the face.
Okay. So I've been provided with the frontal frontal X-ray of the skull. I can see there is a linear fracture at the left mandible, paramedial in location. And there is also some tooth lost on the right side of the mandible, lower jaw. And I'm looking to the other fractures. I can't see any other fracture lines here. However, the mandible is rounded, so I should have another fracture line on the other side. Yes, there is another one on the left upper part of the ramus. So I will relay these findings immediately to the orthopedic surgeon on call.
So you saw two fractures. One was involving the symphysis menti. The second one was?
Here in the left side of the upper part of the ramus mandible.
Okay.
Yeah, here. Maybe you don't see my marker.
No, I can't see your marker.
Yeah, I will ask.
That's all right. That's fine. Okay, we'll move on to the next case.
Okay.
Just give me 1 second, okay?
Mm-hmm.
So this is a young female patient who has presented with history of fever and weight loss.
Okay. I've been provided with the chest X-ray of the adult patient. There is a right hilar mass, very prominent right hilar mass, and I can't see any consolidation or any changes around the mass. There is no pleural effusion, no pneumothorax, and no other mass in both lung fields. The heart with the normal shadow, the trachea is central. I would like to see also the bony structures. I can't see any remarkable things in these structures. Nothing beneath the diaphragm or in the other hidden areas. So my striking abnormality here is the right hilar mass. And there is some prominence on the right paratracheal area also. So this gives me, I will relay these findings immediately to the referred clinician and will write to see if there is any previous images to see the progress of this lesion. And
there's no previous imaging available.
Okay, then I will flag this report and will organize immediately a CT for this patient to delineate the underground lesion. And
what are you thinking about? Like I said, this is a teenage female patient, so you have to justify the CT in this age group.
Well, actually, it is well defined in outline, and I just learned that she's a teenage patient, so it could be a vascular malformation or AV. However, AVM is more peripherally situated, but this is more central. So it could be vascular again or some malformation. So that's why I need CT or CT angio just to be sure of this abnormality much better.
I agree that the final diagnosis CT will be very helpful, but I want to hear your full differentials for this sort of appearance and the summary of the findings. Is this the only finding you're concerned about, or did you mention you saw any other finding?
Yeah, I can see there is another right paratracheal increased density, which is longitudinally, and it is well outlined in the outer border. So it looks like also another vascular, or it is continuity of this one. However, it is not so clear in the middle part. So it could be a venous anomaly, or I'm not sure if, or this is right-sided aortic knuckle. It could be, yeah, this is right-sided aortic knuckle because I can see the aortic knuckle on the left side.
And fine. So you said this was a hilar mass, right?
Yes, yes.
And you said there is some paratracheal soft tissue.
Yeah.
All right.
Yeah.
So just give me your differential for hilar masses first.
So this is right-sided.
Generally speaking.
Yeah.
Yeah. Generally speaking, right-sided hilar masses. What would you think?
So this is, it could be an aberrant artery or
Yes, it could be, but generally, what other differentials would you think for a hilar mass? What
a
is the first thing that will come to your mind?
well, a hilar mass, it could be TB. It's like lymph nodes and TB,
Okay.
or not in this age, of course, malignancy it could be, or
So you said lymph nodes. Okay.
lymph node, vascular, or
Mhm.
any mediastinal lesion. Mediastinal lesion
Right.
could be bronchogenic cyst. However, this is not in the shape of cyst, or thymoma, teratoma. These are all other mediastinal
All right.
lesions.
So this patient was followed up a little later. She was treated for infection, and this is about a month later. What do you see now?
After treatment of post-infection. Okay.
Yeah, possible infection.
Well, there is a bilateral hilar masses, and there is enlargement of the paratracheal shadow. This gives me the impression of Garland triad, which is evident in sarcoidosis. However, in the history of this patient, there is infection and treatment accordingly. So I will again, bilateral hilar masses symmetrical. This gives me also the suspicion of lymphoma in this patient. Because there is also right paratracheal lesion, and again lymphoma, sarcoidosis, and tuberculosis also in the list. However, my top differential will be here lymphoma, because bilateral symmetric with paratracheal lymph nodes. So I would relay these findings to the clinician to be discussed in the chest MDT, and
Right.
yeah.
So can you just scroll?
Yes. No, it is static, I think.
Yes.
Okay.
The other way.
Yeah. Okay.
No,
This is the same patient, or?
Same patient. Yeah. We've done the CT for her.
Okay. I don't know why it is not going.
One second. Let me just, can you use the arrows right and left?
Okay. I'm
Not okay. Up and down.
even not.
Okay. So mouse, do you have a mouse wheel, or you can
No,
just select this option? Yeah. Click and scroll. Now just click once. Click and scroll.
Okay. Okay.
You know what? Let me just scroll for you.
Yes, please. It will be
Okay.
good. Okay. So I've been provided with the axial images of CT. I can see there is a prominency. Yeah, there is paratracheal lymph nodes and the hilar, bilateral hilar lymph nodes, subcarinal. So there is diffuse mediastinal lymph adenopathy. There is also para-aortic and mesenteric. Yeah, there is a lot of conglomerate lymph nodes in the para-aortic aortocaval region, and even some few retrocaval. So this gives me the evidence of diffuse lymphadenopathy, which is most probably due to lymphoma. The spleen also looks big, and
So can you stage this lymphoma for me?
Yeah, this is staged because it is on both sides of the diaphragm, and it is also, this is a stage 3. Yeah, stage 3.
Your next case, this is also a 14-year-old girl who presented with pelvic pain and mild fever.
Pelvic pain and mild fever.
Just one second. Let me do it. Just leave the mouse.
I just left everything. Yeah. Okay.
Okay, fine. So I'm gonna scroll for you.
So an adult patient with pelvic pain.
No. I said 14-year-old girl with pelvic pain and fever.
Good. So these are provided images, axial images, contrast enhanced. I can see. I will just, yeah. There is a huge cystic lesion in the pelvis, pushing the bladder anteriorly and extending into the abdominal cavity. And there is some another lesion, maybe it is viscous, I'm not sure of it, but it shows a well enhancement surrounding. So this is a multicystic lesion extending from the pelvis to the abdominal wall and in teenage. So it could be ovarian cyst, massive ovarian, multicystic ovarian cyst, and or yeah, with fever, because one of the cysts looks well in
mild fever. The inflammatory markers are not significantly elevated. She has mild fever.
Yeah, but I can see some structure, cystic structure with a ring enhancement around it, where there is a rounded enhancement. So I think that it is extending to the, yes, downwards below the cervix. Maybe it is, yeah, it is labial, maybe. I'm not sure. This is very big, huge cyst. So yeah, there is no ascites, no others, other solid organs looks.
So upon asking some more discussion with the clinician, it comes to be known that this patient has primary amenorrhea.
Yeah, so if this primary amenorrhea, this could be hematometria or hematocolpus, because yeah, the cyst is extending through the vagina also downward.
So which is it? Is it hematometra or hematocolpus?
Hematometria, because the hymen maybe is not imperforated, so the blood is continuous to the down. So this could be due also one of the Müllerian deformities, or as Mayer-Rokitansky Koster-Hauser syndrome. And I can't see.
You said you said you're thinking of hematometra, right?
Yeah, yeah. But
so hematometra is blood in the.
Yeah, blood in the uterus, but I can't see the uterus here. There is only cystic structure. It is maybe it is.
So what would you think? What did you say the most common cause of primary amenorrhea is?
Imperforated hymen, or yeah, or septum may be there. So
maybe a sagittal will help you see it better.
Or maybe even. Yeah, there is a huge cystic lesion. So there is, I can't see the uterus or any structure in the uterus. So I think this is one of the Müllerian deformities or abnormalities. It could be aplasia. It could be hematometria.
So if it's Müllerian abnormality and the uterus is not formed, where is the blood coming from?
Ectopic endometrium, maybe endometrial cyst. It could be. Yeah.
So what structure do you think this is?
Maybe that one is the uterus, and this are all big cystic lesions from the ovaries. Because it is very huge, I can't. Maybe because that one is enhancing, so it could be endometrium and the cyst within the lumen, and these are huge adnexial cystic lesions. For this I need MRI more helpful in this situation, or ultrasound at least, to know the cystic nature of this huge cyst.
So what would you advise to the clinician?
I would advise the clinician to do an ultrasound, first of all, for the pelvis, to see the cystic components, to delineate them much better. And will be discussed again in the gynecologist MDT for the possibility of organizing MRI or examination. Yeah.
Fine. So this is an 80-year-old woman who presented with acute onset right hypochondrial pain.
Okay, right hypochondrial pain. So in 80-year-old woman, I can see there is a well-defined calcified lesion in the right hypochondrium. It could be due to the liver. However, the breast silhouette or tissue is also superimposed on the liver. It could be also due to the a mass, calcified mass within the breast, right breast. I can see
So recent mammography was normal.
Was normal. Okay.
Yeah.
So that it could be also then in the right hypochondrium and a well calcified lesion in the hypochondrium, an old lady. First comes to my mind is calcified hydatid cyst. I would like to know if she's an immigrant from an endemic area or so it could be hydatid.
Yeah, she is actually an immigrant. So is that your only finding, or do you want to tell me something else that you're seeing on the X-ray?
Yeah, there is other calcified lesions on the left side also in the region of the spleen. So in both organs, it could be either hydatid or tuberculosis, granulomatous disease, I mean. And I'm looking also beneath the right hypochondrium, beneath the liver, there is another hyperdense lesion. I'm not sure if it is within the trace of the right kidney. So there is multiple calcified lesions. Yeah. Maybe zooming is better. I'm just looking here to this area also, because there is some calcification on the right.
You can take the mouse. Just show me what you're talking about.
I saw one here. And
just click and point. Click and move the mouse.
Can you see my mouse? Yeah. So surrounded in the right hypochondrium, and there is multiple calcified lesions in this side. It could be spleen or even in the kidney. And there is maybe here someone, because it's not clear, so maybe here is some calcifications or it is bowel. So multiple calcified lesions, specifically in the liver and the left, supposed to be kidney, kidney. So this is most probably due to tuberculosis.
So what do you think? What do you think the cause of the right hypochondrial pain is right now?
Right hypochondrial pain. It could be calcified.
Yeah, what is
calcified gallbladder also, as there is a pain here. So it will be porcelain gallbladder and calcified, as there is.
Does that look like? So you mean the hydatid cyst that you previously mentioned could also be from the gallbladder, right?
Yeah, I'm just enumerating the differential diagnosis.
Yeah, sure. I'm trying to help you list it out. So like one of the differential recalcified projection over the liver region could also be a gallstone or a porcelain gallbladder.
Yeah.
Alongside hydatid cyst, right?
Yes, or tuberculosis. So my top differential, as it is coming from the endemic area, this could be hydatid. Yeah, it is multi.
So we have a CT for this patient. I'll just scroll through.
Yeah, thank you. Yeah, there is a well-defined calcification, and there is another. This is there was some lamellated stone maybe in this ectopically situated within the within the small bowel. Maybe just go up. Yeah, what is this? Yeah, this is there is some lamellated stone. I think this is. Yes, this is another thing. This is ectopic gallstone ileus. It is a gallstone in the small bowel and causing dilatation of the bowel.
Why small bowel? Why small bowel? This is a gallbladder.
Yeah, this is. This is a hepatic flexure. No, it is ascending colon actually in the hepatic flexure. Sorry, and there is dilatation.
No. Have you identified the gallbladder first?
No, this is gallbladder. Maybe it is enlarged and dilated. Yeah. So there is two calcifications. Actually, there is three calcifications. One in the calcified hydatid in the liver, and one in the gallbladder, which is enlarged and includes big calcification. And there is also the left kidney shows calcifications and fatty infiltrations. It could be xanthogranulomatous nephritis because there is multiple fatty and calcific contents, and there is very thin cortex in the kidney. The left kidney,
Right.
kidney is unremarkable, and there is the pancreas looks prominent or hugely, yeah. There is multiple hypodense lesions in the epicentered on the pancreas with multiple calcifications within it. Yeah, so it could be multiple cysts within the pancreas, or if the patient has acute pain, so this could be pancreatitis. Yeah, pancreatitis with calcifications at the body and the head of the pancreas.
Right hypochondrial pain. It's not. They're not really concerned about pancreatitis because clinically there's no epigastric pain not radiating to the back.
But I'm seeing, yeah, yeah. These I can see there is some big pancreas here, hugely enlarged.
So
Yeah.
it could be an incidental lesion, but can you tell me the differential for this?
For the pancreas, it could be pancreatitis, autoimmune pancreatitis, because it is very hugely big, or maybe it is, yeah, it is old age. So this could be grandmother mucinous cyst adenomas, yeah, in the pancreas, because they are big cysts, not small. So yeah, it could be also that. And also in old age, always we should think of possibility of carcinoma, pancreatic carcinoma in the region of the pancreas.
Pancreatic adenocarcinoma, you mean?
Yeah, pancreatic adenocarcinoma. Other possibility in old age, it could be. So I would relay all these findings to the referred clinician to be discussed in the.
What finding over here is the most concerning for the clinical presentation and for the clinician? Because this patient has multiple findings, what should he act upon first?
The first comes the gallbladder with a huge calcification, and because the patient has right hypochondrial pain, so it could cause some symptoms. But however, the pancreatic lesion also gives me a very big suspicion, because even if it is incidentally discovered, but it could be an important thing, and I should relay these to the clinician to be discussed in the hepatobiliary MDT for the possibility of the biopsy and ERCP or MRCP or both of them.
Fine. Okay, we'll stop there.
Yeah.
Dr. Asad, are you keeping time?
Sorry, sorry, I sent you the message. Are you keeping the time? So, but actually, I kept the time for 15 minutes, which for over 5 minutes back. So I thought.
All right.
Yeah. So
no. Actually, last time I saw you were keeping time, so I just expected you to keep time, so I didn't bother looking at the time.
Yeah, no problem.
Yeah, I think we just went a little ahead. So we'll start the discussion now. This was your first case. Also, I'll just open the chat if anybody wants to ask any questions. So you were spot on. There's a fracture here, and the important thing to mention over here is the ring structure of the mandible, and look for that, diligently look for the second fracture. However, you went to the right mandibular ramus. Actually, the fracture, sorry, you went to the left side. The fracture was actually on the right side. This is a fracture.
Okay. Yeah, because
okay, and yeah, you can see the.
I thought it is due to rotation. Yeah, right.
Yeah, no, this is too much to be rotation. This completely the ramus is detached and sublux. Also, there is some subcutaneous emphysema, right? You can see these gas locules overlying the mandible. Any other ring structures, any other ring fracture that you can tell me?
Here in this view?
No, generally speaking, any other?
Orbit, or any rounded structure, orbit, obturator, pelvis, ankle joint, hand, anywhere. All this,
what is the name of the fracture which involves the ankle joint? and also involves the proximal fibula?
Meissonier fracture. Meissonier.
Yeah, that is correct.
Yeah.
Okay, so this is your second case. So this is actually paratracheal as well as right hilar mass is prominent, but you can also see there is a left hilar mass. Okay, this is a rounded opacity overlying the left hilum.
Right.
Okay, right, you can make it out. Maybe retrospectively,
it's
at least you can
not
make it out.
Yeah.
Yeah. So before jumping to the fancy diagnosis, it's important that we come systematically. So hilar mass, rounded hilar mass, paratracheal opacity. First thing you'll say is lymphadenopathy. Next, you'll say something like vascular structures, or bring in the fancy differential over here. We thought it was lymphadenopathy, so we suggested treatment, infection. She also had some fever. Second possibility, we did give it as lymphoma, but then they didn't take it seriously at that time. The patient was 14 years old. This is a follow-up X-ray, and over here you have quite clearly the paratracheal widening as well as bilateral hilar nodular masses. And then, in fact, even on the X-ray, you can comment that there's hepatosplenomegaly.
Yeah.
Okay, when you're saying lymphoma, always try to comment on the spleen as well. Obviously, on the CT, there's no doubt. There is like multiple conglomerating lymph nodal masses in the mediastinum as well as hilar and below the diaphragm in the para-aortic regions, exactly like you said. There's also hepatomegaly, splenomegaly. I also feel there are some, subtle lucent lesions within the spleen, which could be lymphomatous infiltration.
Great.
So this was lymphoma, and yeah, you have to know the classification and grading for lymphoma and our classification. And this is stage 3, actually, as you said.
Yeah, thank you. Good case.
The third case, you really got confused. Again, we have to kind of come through the basics. So initially, I know it can be quite confusing, but when I gave you the history of primary amenorrhea, you first thought of unruptured hymen or unperforated hymen, imperforate hymen. So I was just thinking what to show you actually. So this is the uterus, right? This is the cervix. All of this is vagina.
Yeah. Oh my God.
Yeah, and the imperforated hymen is here.
Good.
So the patient had been complaining of pelvic pain for quite some time, and they were ignoring it until she developed some fever, because of which they brought her to the hospital. Okay, so this is actually when you do CT for an imperforate hymen, this is the typical appearance. Generally, we don't do, because that's the clinician directly, they will suspect imperforate hymen, and there's a simple clinical test to see if the hymen is perforated or not, and they will perforate it themselves without needing additional imaging. But the cases which they do CT, this is a typical appearance. The vagina will be this distended. So this is hematometrocolpus.
Hematometrocolpus. Okay. Thank you.
Yes, and the differential here would be of a vaginal septum. Vaginal septum would be associated with Mullerian abnormalities, even renal abnormalities. So that is a bit tricky, but this is a clear case of imperforate hymen. Okay, it's going right up till the vaginal inoculus, right?
Oh, it's extending down.
Yeah, it's extending down this is the left ovary. So the nexa were normal in this patient, actually. No issue in the nexa. So all of the central midline structure, you should I mean, of course, it can still be ovarian, but yeah.
Okay, thank you. Good case.
No issues. So the last case was actually 4 cases in one. I thought we would get through quickly the initial cases, because borderline direct cases. So yeah, like you said, a large differential for this, it could be from the breast, it could be from the liver, it could be from the gallbladder. But if it's from the liver, then the calcified hydrated makes more sense. Okay. Next, we see this, structure over here very clearly in the right hypochondrium below the liver. So obviously, gallstone should come into your mind. In fact, even for this, gallstone can be brought into the differential. Porcelain gallbladder could be brought into differential, but this typical pear-shaped opacity over here is definitely a gallstone. And then here you have a branching calculus in the left kidney. So directly you should say Staghorn calculus for that, even without seeing the CT. And given the picture of the patient's presentation, right hypochondrial pain with a large gallbladder calculus, in fact, even over here, you can see, gallbladder wall appears a bit thickened. You should directly suggest that you're thinking of cholecystitis, and you should recommend ultrasound evaluation next for this patient. Anyway, so ultrasound, we should, like, this confirms a hydrated, like calcified, hydrated, typical layered calcification, septations, whatever. And then you have a large gallstone, quite clearly the gallbladder. And additionally, what I was looking for you to mention was there was fat stranding adjacent to the gallbladder.
Yeah.
Right. And there's some fluid, there's some thickening. So this is cholecystitis.
Yeah.
Okay, so this fluid and everything is related to the gallbladder. This is an incidental finding, and it's a large, predominantly cystic lesion with multiple septations, and the septations have calcification. So it's a multi-loculated cystic lesion. The cysts are macrocystic; they're not microcystic. It's predominantly involving the body and the tail of the pancreas. Okay, so generally speaking, you would think of a mucinous cyst adenoma in this case, given this appearance. Okay, given the age, if there is additional fat stranding, any lymph nodes or anything you see, mucinous cyst adenocarcinoma. Okay, but over here in this case, you have a dilated main pancreatic duct, right?
Yeah.
So just scrolling very slowly over here for you to notice this. The lesion is all over here. The duct is dilated, and over here there's some suspicion of communication with the duct.
Yeah.
Okay, some of the lesion is apparently looking like it's communicating with the duct. So ideally, you should ask for a coronal recon for this.
Okay.
So you can see that the lesion is primarily involving the superior part of the pancreas. The inferior part is like atrophic. And let's just trace the duct. Okay, starting from here, it's going here. This is the main pancreatic duct, and over here, there is communication.
Good.
Okay, and then the rest of the duct is dilated. So if mucinous cyst adenoma, even a serous cyst adenoma, is seen to be communicating with the main pancreatic duct, it becomes an intraductal papillary mucinous neoplasm. Okay, IPMN. Now, again, IPMNs can be benign, can be indeterminate, can be malignant. The criteria that applies for the differentiation is the dilatation of the main pancreatic duct. If it's more than 5 mm, you're thinking more towards malignancy. Also, if you're seeing some enhancing soft tissue components. So, these are like quite thickened walls over here. Yeah. And the size of the lesion itself and the age of the patient, all of this, you definitely have to raise the possibility there are some lymph nodes surrounding it, right? So you'll say this is an IPMN, likely malignant
type
histopathology, mucinous cyst adenocarcinoma type.
Yeah. So I changed my diagnosis from mucinous to IPMN because of this dilated main pancreatic duct.
Yeah, mainly of the dilated main pancreatic duct. If you see any communication and dilatation, you should change it to IPMN. But some of the differentials that you brought in early on, like chronic pancreatitis and I forgot, you said something else. The initial 2-3 are different.
Autoimmune pancreatitis, but
those are wrong. Those I don't agree with differentials.
Okay.
The kidney itself, Staghorn calculus, quite typical. And the rest of the, exactly like xanthal granulomatosis pyelonephritis, it's fatty replacement of the rest of the kidney. Okay, so there's a question if there's gas in the gallbladder.
This is a huge case.
So, huge case. I mean, I thought we would have like plenty of time remaining because the other case is lymphoma and hematometrocolpus. They look simple to me, so I just put this in. This is I think this is cholesterol crystal. I don't think there's gas in the gallbladder. So there's a question in the chat. Okay, so we'll move to the next candidate. Is Dr. Salman online?
Cases. Thank you.
Yes, Dr. Wasif, Salman will be going next.
Okay, great. So we'll just close the chat. There you go, Salman. This is a teenage boy.
Radiograph of both hands, a frontal projection of a teenage boy that show the cupping and fraying of the distal radial and ulnar metaphysis, symmetrical bilaterally, and the abnormality is quite symmetrical. Now I'm looking for any other abnormalities in the rest of the bones. Somewhat similar abnormalities are also there in the heads of the metacarpals bilaterally. Yes, and other than that, the bone density is preserved. There is the trabecular pattern is normal, no fracture dislocation. Although the cortices are slightly more prominent bilaterally. So I would conclude by saying that findings suggest rickets involving the bilateral wrist joints, radius and ulna. I'll talk to the referring clinician.
Do you have any differential for this appearance?
Well, in a child, in a patient with an immature skeleton, rickets is the first differential that comes to mind. As for the fraying of the metaphysis is concerned, I think some anemias or hemolytic anemias and such disorders, hematological disorders, can also cause disappearance. But to me, this appears to be quite typical for rickets.
Rickets is caused by the deficiency of what nutritional agent?
It is caused by the deficiency of vitamin D.
Okay,
and,
so this is your next patient. This is a 30-year-old patient who presented with hemoptysis.
So chest radiograph frontal projection of a 30-year-old person presenting with hemoptysis. There is a well-defined rounded nodular opacity in the right mid-zone. It is very well defined without any obvious calcification or spiculations. I cannot see any other similar nodule in the rest of the lungs, and no other focal lesion in the rest of the lungs. The CP angles, the retrocardiac regions, the cardiac and diaphragmatic silhouettes, the bones, as well as the soft tissues appear unremarkable. So considering a patient's age and history of hemoptysis and the fact that a linear vascular structure is traversing towards this opacity, I would, as a topmost possibility, consider an AV malformation. And I will want to convey these findings to the clinician and discuss the clinical history in detail. And the patient needs further imaging with post-IP contrast CT pulmonary angiogram and venous phase to further.
Do you have any differential for this?
The other differentials for a solitary pulmonary nodule could include a granuloma, tuberculoma, hematoma.
Okay. What can you tell me about this artifact that we are seeing here?
Well, there are a few well-defined tiny metallic density opacities that are arranged horizontally along the long axis of the anterior adjacent rib. I'm not sure as to what this is, but this could be related to some prior intervention. And since these appear to be quite metallic, and one of them is somewhat linear. So we'll also want to ask the clinician about any history of past intervention.
We are not sure. This patient presented acutely to the hospital, and he's not a regular patient at the hospital. So the patient is not in a position to give any more history. What do you think it is? What can you tell the clinician what you think and the general history that you can infer from this X-ray?
You're asking me about this artifact or as a whole, for the
Yeah, I
management?
mean, yeah, put together, like, what can we think has happened before?
So considering the appearance of the other lesion, the patient might be a case of hereditary hemorrhagic telangiectasia, and this might be treated or embolized other AV malformation previously in the past. And to take it further, the patient needs a cross-sectional imaging to delineate these abnormalities and to look
What do
for
you
further
think? What do you
lesions.
think the probability of this patient having HST is? What are the chances that this patient might have HST?
Well, although I can only appreciate one lesion, since the appearance to me it seems quite typical for it, I would want to look for further lesions.
Do you think it is high or low based on what you're seeing right now on the X-ray? Do you think the probability that he has HST is it high? Is it low? Is it in the middle somewhere?
I would say it is high.
Okay. So this is the next case. I'll give you remote control. Can you just ask me for remote control?
I've just requested.
Okay. I would say try using your arrows first. And if that doesn't work, you can try something else. Right and left, right arrows.
I'm using right and left arrows, but
have you clicked once? Are you able to move the mouse?
The mouse is connected. I just moved the wheel, and I think.
Yeah. Okay, fine. If you have a wheel, then perfect. Go for it.
So axial non-contrast CT brain. I would want to scroll through the images first to make an impression. So I have scrolled through all of the images, and in the very first scroll, I haven't been able to see any gross abnormality. However, the anterior half of the pons appears to be slightly hyperdense, and scrolling further down, there is another well-defined hyperdensity in the prepontine cistern that appears to extend into the foramen magnum.
Are you convinced there's something there?
And there is this very well-defined oval-shaped hyperdensity there. And
don't think too much about it.
All right. So I'll now look at the other review areas, and the basilar artery density appears to be fine. The gray white matter differentiation is normal. I've not been able to see any loss of gray white. Well, there is left periinsular hypodensity that is asymmetrically more marked on the left side as compared to the right. And moving on more further cranially, it appears to extend into the left periventricular white matter. So considering this appearance, I am concerned about an acute infarct, and I would immediately convey these findings to the emergency physician and correlate with any history of right-sided weakness. And we'll also scroll through the rest of the images once more to make sure there is no intracranial hemorrhage. And if the patient is within the recommended window, the stroke team can be involved, and the intervention radiology can be involved, and the patient can go for thrombolysis. Or,
Do you usually get interventional radiology involved? Yeah. So thrombolysis or thrombectomy? Why do you want to involve the interventional radiologist?
Say if the patient is in that window, which I have.
What window are we talking? How much is your window?
I've to be very honest, I've forgotten the numbers, but I think if it is within 12 hours, that is the window for thrombectomy. And I think if it is within 6 hours, then thrombolysis is possible. That is intraarterial injection of TPA. And if the interventional radiologist is planning to go for a thrombectomy, then I think it is up to 12 hours.
Should he plan to go for thrombectomy or thrombolysis in this case?
Well, I think he should go for a thrombectomy because with thrombolysis, since this is an evolving infarct already, there will be a risk for hemorrhagic transformation.
And that risk is negated if you just do a thrombectomy?
The risk in that case would be relatively lower.
Okay. Your next case. This is a middle-aged patient who presented with abdominal pain.
So a middle-aged patient presenting with abdominal pain. I'm scrolling through the images, which is just a bit slow on my side. So I'll keep on describing as I'm scrolling. So to begin with, I've seen a large ascites. And then there is a large mass in the epigastrium that is inseparable from the pancreas, pushing the stomach anteriorly. So going further down, the mass is separated with internal hyperdensities, multi-separated, multiloculated, adjacent fat stranding. There is a moderate ascites as well. In my routine practice, I would also have measured the density of this ascites, which to me subjectively visually appears to be slightly hyperdense. Just want to rule out if it is hemorrhagic according to the Huntsville units. So going back into this lesion, trying to see its relationship with the adrenals. Adrenals are separately visible. So the lesion is abutting the celiac artery, which it has mildly narrowed. It has displaced the superior mesenteric artery and vein contralaterally. And it is occupying the body and tail of the pancreas. There is no obvious encasement of the surrounding vessels, but more of a displacement. I cannot see any obviously significantly large lymph nodes. And in my routine practice, I would also have seen the bone window to look for any osseous abnormalities. So to conclude, a middle-aged person presenting with abdominal pain and a large mass that is inseparable from the body and pancreas, with fat stranding and ascites, I will think of considering the internal septations and the enhancement within the septations. I will want to consider a cystic neoplasm of the pancreas. And I would want to convey these findings to the referring clinician, get the pancreatic surgeon on board in the case needs.
What's your differential? Which cystic neoplasm would you consider?
So considering the fact that the cysts are larger than, I would have measured them in my routine practice, but apparently they appear to be larger than 2 centimeters. Body and tail of pancreas involved, no central calcification. So I would think of a mucinous cystic neoplasm. I cannot establish its communication with the pancreatic duct. It appears to have actually replaced the body and tail of pancreas. So I would go with the diagnosis of mucinous cystic neoplasm. And
mucinous cystic. So are you thinking it's more of a benign etiology or more aggressive etiology?
Sorry, Dr. Wasif, 15 minutes are over.
Okay.
So for a benign etiology, had it been a pancreatic pseudocyst, so many internal septations and yeah.
I'm happy with the description you have given so far. Within your differential, are you thinking of a benign etiology or a malignant etiology?
I'm thinking of a malignant of a neoplastic etiology, but the
neoplasms can be benign or malignant.
Yeah, but more of a benign etiology because it has it has displaced the surrounding structures. It hasn't invaded any vessels. There's no surrounding lymphadenopathy. So I would think of a low-grade neoplastic lesion or a benign neoplasm.
Fine. We'll go to the discussions. I think you did very well. I like the pace with which you're going and giving the descriptions in detail. So the first case, teenager with wrist pain. The presentation, the appearance on the X-ray is typical, I mean, characteristic, and it's a start of phlegm. It's obviously rickets. The findings over here is like fraying of the metaphysis, where you have this indistinct margin. Okay, you don't have a sclerotic margin here. There's also splaying, in which, it's more prominently seen with the ulnar metaphysis over here. The metaphyseal margins are splayed, they are displaced peripherally, and there's also cupping. Okay, so these are the three main things: fraying, splaying, and cupping. And together, these are quite specific and characteristic. They give you only the diagnosis of rickets. I'm not convinced there's anything in the metaphysis of the metacarpals over here. Metacarpal heads also, I think you said. So the differential that you can put over here is that of scurvy. Scurvy would also cause metaphyseal widening. However, the mineralization in scurvy would still be there. I mean, it wouldn't be so deficient. Over here, we don't have any mineralization. So you'll have a sclerotic line, which you will see under the physis in scurvy, which is called the, I think it's called the Frankel's line. And then below that sclerotic line, you'll have a lucent line, which is called the Trommelfels line. Other than that, you'll also you'll have the cupping. But then in scurvy, you'll call those cupping as spurs. You'll call them as Pelkin spurs. Okay. So I feel most closely rickets will resemble scurvy, and both of them involve the long bones, basically the knee joints, wrist joints, not the small joints. Other thing is, so over here we call it fraying. And the long differential that we have is for metaphyseal flaring, which is Erlenmeyer for flask deformity. So the differential that you were giving, hemoglobinopathy, storage disorders, glycogen storage disorders, and even osteopetrosis, so lead poisoning, all of that is flaring, not fraying. So this is FRAY. That would be FLAR. Okay, so just keep that in mind. Also in scurvy and in rickets, you have this rosary beads appearance. Okay, so if you see ratcheted rosary of the costochondral junctions, if anybody asks you for differential, you can say scurvy, scurvitic. So second case, hemoptysis, straightforward, you went for an AVM. Okay, the lesion is well defined, small. There is a vascular pedicle which is connecting to the hilum. No points in making a correct diagnosis over here. However, this is a vascular closure device which was used in this patient to previously close another AVM over here. So likely this patient has multiple AVMs in the lungs. Okay. And the possibility of having HST with a single AVM is 1/3, 30%. And if you have two or more, then you have 2/3, which is 60%. So as the number increases from 1 to 2, the possibility goes up above 50%. Okay, so whenever you see an AVM, you have to raise the possibility of HST. Here, this is the post-embolization film for this patient. They have only coiled the feeding artery. They didn't put anything in the vein over here, which you can still see. So I had the CT for this patient. I'm not showing because, it doesn't add anything as the same, just AVMs. So next case here, these are all artifacts. Okay, so it's very hard to call. The pons midbrain over here is going, and then you have some CSF, and then this is actually the pons, and there's an artifact here because of which this is getting hypertension. Anyway, I don't blame you for getting confused with that. So there is insular ribbon sign here. You need to use some of the buzzwords. So there is a hypertensity involving the left, asymmetrical hypertensity. You don't have to say increase because there's no hypertensity over here. So there's asymmetrical hypertensity involving the insular ribbon sign. When you say insular ribbon sign, you immediately think of the adjoining sign, which is a dense MCA sign. So I'm trying to look for the dense MCA sign, and the MCAs appear symmetrical. There's no hypertensity in the MCA. However, in some of the branches, like you can't see any of the branches on this side. So this side, some of the branches are distended, and they appear hypertense. So if they were the same caliber and this as on the other side, then you could say it's properly artifactual. But since they're so obvious, we can raise the possibility of thrombus within the MCA branches. I don't know why I can't get this to school now. So here you have these thrombus branches. I don't know whether they can do thrombectomy for the smaller branches, unless you see like a hypertense clot within one of the bigger MCA branches. I'm not sure if you can recommend a thrombectomy, but what you can recommend is a CT angiography to confirm the clot. So before passing the case on to an interventional radiologist, you should always just, my next step would be to do a CT angiography to demonstrate this thrombus properly. And you need to know what the stroke window is. I think now it's before it used to be 4 hours. Now it's extended to 6 hours, and some people even do it at 12 hours. Hemorrhagic transformation is actually an acceptable risk. Nobody chooses one therapy over the other because of hemorrhagic transformation. I've never heard that, but this is a follow-up MRI of the same patient. Over here, you can see on the MRA, almost no middle cranial artery branches are seen on the left side, whereas on the right side they're so prominent. And obviously on the PWI, the stroke is much more established. So I put the last case in just as a revision, because normally you hear and then you forget, and then so it's actually mucinous cyst adenocarcinoma. So remember, when you say cystic neoplasm, they are looking for a little deeper than that. They just don't want to hear a general differential subheading. They want like a proper diagnosis. So your description was spot on. It's involving the pancreatic body and tail, large cystic lesion with multiple loculations, and you have thick septae, maybe somewhat enhancing soft tissue. No, there's no enhancement. There's just hyperdense soft tissue within. No calcifications, large macrocystic structures. And over here, you can see that there is mesenteric fat stranding, right? And there is ascites, which is intraperitoneal. So there's no longer a retroperitoneal lesion. This is actually invading the peritoneum. You also see multiple collaterals. Some of the collaterals are feeding the tumor itself. The other collateral, this big collateral, is actually the splenic vein, which is going all the way around. It's going down here and then coming back here and then joining the superior mesenteric vein. So if you see, the splenic vein is actually invaded by the lesion and it's completely thrombosed. So this is actually a collateral pathway for the splenic vein. So these are all signs of an aggressive nature of the lesion. So proper diagnosis over here would be that of a mucinous cyst adenocarcinoma. Neoplasms can be benign, can be malignant. Cystic neoplasms can be benign, can be malignant. And mucinous cystic neoplasms, you have adenoma, cyst adenoma, and you have cyst adenocarcinoma. So you have to be a little specific there. For serous, you only have serous cyst adenoma. You don't I think it's very rare to have cyst adenocarcinoma. So if it's actually a lesion which is within the head of the pancreas and it's showing a bunch of gray appearance with microcystic loculations, even if you see that, it's quite close to an adjacent bowel structure or any other thing, and you're suspecting invasion, you should still be very cautious about calling it a cyst adenocarcinoma, because a chronic cyst adenoma can give such an appearance. Okay. However, mucinous, you have a mucinous adenocarcinoma. So you can say, I'm suspecting this to be an aggressive lesion, probably a mucinous adenocarcinoma. I didn't go through the chat. Let me just check the chat. All right, so nothing in the chat. We'll move to the next candidate.
Dr. Waleed, are you going first?
Yes, I'm ready. Hi, Dr. Wasif.
Hi, Turi. So your first case, 30-year-old patient with chest pain.
This is frontal chest radiograph of patient with complaining of chest pain. I am reviewing lung apex appear intact, retrocardiac appear intact also, no subdiaphragmatic problem. There are bilateral congested boss hila with evidence of venous diversion to the upper side. There is diffuse reticulation noted involving both lung fields with suspected curly B line.
I think it's okay because there is an increased blood flow, but have you completed your search? Can you tell me about the rest of the film?
There is a bilateral hyperdense both humeral heads with sclerosis, and there appear to be dorsal H-shaped vertebrae with all of this is suggestive of sickle cell disease. I would correlate with previous film if available, and if it is the first presentation, I would convey my finding to the referring physician.
Any other findings that you're seeing in this X-ray? Anything else you would like to tell me?
Chest skeleton also appear relatively sclerotic. I am suspecting that there is right side mid-zone opacities.
All right. Anything else? Okay, that's fine. No issues, no issues. You got all the major findings. Okay, so next case, this patient presented with periumbilical pain. Can you ask for remote control?
Yeah, okay, just a minute. Yeah, I'm requested that.
Okay.
It is not working, it's scrolling.
Just 1 second. 1 second, no problem. No problem. Okay, now take back the remote control.
Okay. arrows is not working. I am have
right. It should work, which is surprising. Right, left, up, down. Nothing.
Not working. Sorry. I will try to use.
Yeah, use the click and scroll.
It is jumping.
Okay, just 1 second. You can try dragging it from here. Just dragging this on the bar on the top.
It is also still jumping. It is so rapid. Sorry. I will take a view of. This is a CT. This is actually a CT enhanced study of abdomen and pelvis within portovenous phase. I will take a look first. Sorry, it is not going good.
Just 1 second, 1 second. Maybe it's gone. Okay, try again now.
The prominent finding in this study is dilated, distended appendix with surrounding fat stranding and few mesenteric lymph nodes. Solid organs appear unremarkable. In my routine work, I would like to review the case in lung window to exclude the possibility of pneumoperitoneum. There is a rim of free fluid noted perihepatic. I think it is diaphragm. No, it is diaphragm. So these findings are going with acute appendicitis. I would correlate with patient white blood count and inform their physician about.
White blood counts are normal for this patient.
So I am suspecting mucocele, appendiceal mucocele for the dilatation of the appendix. However, still there is an element of inflammatory changes noted around.
Can you show me the inflammatory change?
Just a minute. I think there is surrounding subtle fat stranding around it. However, first possibility of mucocele must be considered. I would confirm my findings to the
What is the most common etiology of mucocele?
The most common etiology for mucocele, appendiceal mucocele is adenocarcinoma.
Adenocarcinoma of the appendix?
I think carcinoid may be, but I couldn't see any signs of carcinoid here.
So if you say it's a mucocele, is there a size criteria for you to differentiate between normal routine appendicitis versus a mucocele?
Normal appendix must not exceed 7 millimeter. If more than 7 millimeter and surrounding with inflammatory changes, I would suspect appendicitis. I think mucocele above 1 centimeter.
Okay. And when you see a mucocele, would you be concerned for anything? Would you recheck anything?
I am suspecting about. I would be worried about rupture and pseudomyxoma peritonei. However, here nothing around the liver and spleen could be detected.
Okay. Okay. So, any other pathology for an appendiceal mucocele that you can tell me?
No, I couldn't remember.
What situation can lead to an appendiceal mucocele?
Obstruction of the lumen of the appendix. It could be inflammatory or due to malignant process. That's what I remember.
Okay. So this is your next case. This patient presented with seizures.
This is axial CT brain of patient presented with seizures. This is axial non-enhanced CT. Scrolling also not working, sorry.
I think I'll just scroll for you.
Okay,
You're
please.
struggling a lot with the scrolling.
Thank you.
Yeah.
There is an area of vasogenic edema noted involving the left parieto-frontal region. With the presence of vasogenic edema, I am suspecting a space-occupying lesion. However, I couldn't appreciate one in non-enhanced study. I would convey my finding to the referring physician and recommend for enhanced CT or MRI brain.
Which MRI sequence would you like to see?
MRI.
Let's start with this one.
This is FLAIR MRI revealed significant vasogenic edema noted around involving the high frontoparietal region. Also, there is no obvious mass lesion couldn't be detected within this FLAIR and T2 weighted sequences. So I would like to see T1 post contrast. This is T1 post contrast revealed. There is nodular leptomeningeal enhancement involving the almost bilateral, but mainly involving the left frontoparietal and right frontal region. In this situation, I am worried about metastasis if the patient is known primary. So
no history of known primary. This patient is 30 years old.
30 years old. So I would correlate with inflammatory markings because I am suspecting TB versus sarcoidosis in young patient.
The inflammatory markers are elevated. What would your first differential be?
So my differential here would include the TB versus sarcoidosis. Other possibility of herpes simplex encephalitis would be must be included. However, this position is not typical for it. It typically involves temporal regions.
But it would also show pachymeningeal enhancement. Sorry, leptomeningeal. Herpes simplex.
No, actually no, not presenting leptomeningeal enhancement.
Okay. This is your next case. This patient presented with right abdominal pain. This patient is 50 years old, female.
Axial CT, enhanced CT in arterial phase of 50-year-old patient complaining of right abdominal pain. This is diffuse. This is sickening noted within the terminal ileum with free fluid noted within the abdomen and pelvis. Congested mesenteric vessels also noted, and mild fat stranding noted within the right iliac fossa. My first differential for a case like that would include inflammatory bowel disease. I would like to review other bowel to exclude the possibility of skip lesions. Other small bowel appear. Also, there is regional area, the duodenojejunal area noted involving with this sickening also. So my first differential would include.
Can you show me?
Yeah, here. Just here's this one. And going to the duodenum and proximal here, this one. So my first
This is similar. You would say this is similar to the thickening
No,
of the ileum that you saw.
it is less like it is less than this in the right iliac fossa. However, it would raise the possibility of skip lesion. So Crohn's disease will be my first possibility.
Any other differential?
Other differential would include infectious process like ileitis, TB, lymphoma less likely because there is no obvious mass could be detected, no lymph nodes could be detected.
Anything else?
If there is a primary, it may be
No primary.
Congested mesenteric vessels. No, I can't remember anything else. Just Crohn's, lymphoma, ulcerative colitis.
How would you manage this patient?
I would confirm my finding to the referring physician, and there is evidence of cholecystitis with the surgical clips. I would confirm my finding. It is going with inflammatory bowel disease. I would confirm my finding to the referring physician and refer the patient for surgical MDT for management.
Management of the inflammatory bowel disease. Okay.
Yeah.
Do we still have time, Dr. Asad?
We are left with 40 seconds only.
Okay, so I'll give you 40 seconds more, Dr. Walid, because you didn't read the diagnosis in this one. Can you see something else? Any other thing coming to your mind?
Maybe.
So management-wise, would you see the previous limbs or not important in this case?
But yeah, comparison with the previous study is important for progress of the case, and follow up with MR enterography is.
So this is the previous study.
The previous study. There is, I think, there is hernia noted within the right iliac fossa, but containing fat.
Anything else?
Portal vein is thrombosed here. There is portal vein thrombosis and superior mesenteric vein thrombosis. This is would be other possibility of ischemic bowel disease.
Right.
This is a hernia.
Okay.
I think Spigelian hernia.
Yeah. Okay, so we'll go to discussion.
Okay.
So overall, you did very well. Actually, I like your pace. I mean, you're not giving any fancy differential. You're going to the most common things. So in this one, again, I agree there is like increased vascularity and maybe even curly B lens if you see hard enough. But if it is not striking, then I would suggest that keep looking at the film until you see something striking, because normally the abnormalities that they show in the exam are quite striking and they directly catch the eye. Okay, you can say, I'm just looking at the lung fields, I'm looking here, there. And then obviously this is striking, there's bilateral humeral AVN, sclerosis. Okay, there is mild cardiomegaly and increased vascular markings, like you said. Additionally, there is HA vertebra too. The only thing you missed is here.
Left splenic, splenic flexion.
The splenic. Yeah, so this is autosplenectomy. This is a CT of this patient just to show how an autosplenectomy looks like.
But calcification is not appear in X-ray.
Yeah, the calcification is not appearing. I think the X-ray is taken even more later. The spleen was completely disappeared at that point. So you can see the sclerosis in the bones, and here you can clearly see So if you compare with this with the X-ray is taken at a later date, so the collapse is even more,
Right.
even more obvious. And there were actually in this patient, there was a bone in which was involving diffusely all of this, so quite progressed sickle cell anemia.
Mhm.
Your next case. So straightforward, you went for mucocele, and I don't agree that there are like inflammatory features that we are seeing, although there is some fluid. So yeah, might as well say there are some
Dr.
inflammatory
Wasif,
features
we
and
cannot
probably
see the image.
yeah.
Dr.
My
Wasif, we
bad,
cannot see the
yeah.
image.
Yeah, my bad. Okay, so more than 15 mm has a high correlation with mucocele. 13 to 15 mm can be either infection or mucocele. 7 to 13 mm is inflammation. So generally what happens is you get an appendicular which causes secretions to accumulate within the appendix. Now these accumulated secretions, they can either inflame the appendix and lead to appendicitis, and then you might have a rupture, you might have phlegmon or peritonitis or whatever, or it may be very indolent and they might collect over a long time and become mucocele. So generally speaking, in mucoceles, we don't see inflammation. If it was inflamed, it would be appendicitis. Obviously, there's also the condition where a mucocele can become infected. In those situations, we'll see gas foci within the mucocele. So you can say, this is like a complicated mucocele with infection. However, the most common etiology for an appendicular mucocele is mucinous cyst adenoma. Again, mucinous cyst adenoma of the appendix. So when we say mucinous cyst adenoma, like in the case of pancreas, we should also think about mucinous cyst adenocarcinoma. Okay, so mucoceles can be benign, can be malignant. Generally speaking, most common, they are benign because of mucinous cyst adenomas. However, if there is wall thickening, I think also lymph nodes or metastasis, I'm not sure. But if you see aggressive features, then you can say mucinous cyst adenocarcinoma. Whenever you say a mucinous tumor of the appendix, immediately you should look at the margins of the other abdominal organs to look for any mucinous seeding of the peritoneum, scalloping of the liver, just to rule out pseudomyxoma peritoni. So even though your diagnosis was spot on, I felt you were rushing towards management. You were not giving the pertinent negatives in detail. So yeah, don't jump to conclusions and say things that are not there until you're convinced, okay, there is definitely, it might be a simple case of appendicitis. Appendicitis do come in the exam, but just be very cautious. For example, I got a case of diverticulitis in the exam. Sigmoid, no, it was cecal diverticulitis. I freaked out. I said it can't be the simple, and I looked left, right. So in the end, it just turned out to be diverticulitis. That can happen, but generally you have to give it time. Don't just jump and say the most obvious thing and leave it at that. This case, you did very well. This is just vasogenic edema. There's nothing else you can say on this. You said frontoparietal. On the CT, I'm not too convinced that it is involving the parietal. However, on MRI, we can see it's definitely involving the frontoparietal region. No mass lesion, and the enhancement pattern of nodular left meningeal is fairly typical. The only differential, even though most commonly they involve the basal cisterns and the basal regions. However, nodular leptomeningeal enhancement, TB versus sarcoid. This patient was an IV drug abuser, 30 years old, and here we have his X-ray. Again, you can see the paratracheal widening, and this was eventually diagnosed and treated as TB. Last case. So had you asked for the previous, I think you would have got the diagnosis more easily. So always keep that in mind. And here what you have is a congested mesentery, free fluid, circumferential thickening, layering, and I don't know, is there something missing to say that this is not venous ischemia?
Hypoenhancement.
hypoenhancement is not that prominent. Actually, sometimes you can even have hyperenhancement. Venous ischemia. We're not talking about arterial ischemia. So the arterial supply is still there. So in this situation, you should always look for the superior mesenteric vein.
Right.
And even if you're saying inflammatory, always look for the superior mesenteric vein. And where's the superior mesenteric vein?
Superior mesenteric vein.
It's not there.
Right.
It's completely replaced by almost a cavernoma. Cavernoma is transformation of the superior mesenteric vein, right?
Right.
There are so many collaterals, and you can see that extension up until the level of the portal vein. So here also we have like multiple splenic collaterals,
Right.
periportal collaterals. So this is chronic portal vein thrombosis leading to cavernomatous transformation of these veins. And I feel at this point there is also thrombus which has developed in those collaterals, which is leading to this venous ischemic changes. So this was 4 years ago. This patient had a well-developed thrombus within the portal vein as well as the superior mesenteric vein.
Right. Thank you, Dr. Wasif.
Thickening, mesenteric congestion, venous ischemia is not enough to say ischemic infarct, or in case of bowel, you have to specify whether it is arterial or venous. If you get paper thin bowel walls, then it is going more towards arterial ischemic changes. Also, you'll have nematosis intestinalis when it is arterial. You don't have those things in venous ischemia. You just have this thickening and congested mesentery, almost watery appearance of the mesentery.
Okay. Thank you. Thank you very much.
Most welcome. Most welcome, Dr. Uri. So next we have
Dr. Wasif, I'm here.
Dr. Same.
Yeah.
Oh, sorry, I didn't go through the chat.
No problem. Take your time.
Repeat 13 mm, please. Okay, so this is for appendicitis. Appendicitis, the caliber from 7 to 13 mm is appendicitis. 13 to 15 mm, it can be either appendicitis or appendicular mucocele. More than 15 mm, high specificity and sensitivity for appendicular mucocele. Management of acute brain ischemia. I think it's better that I just share this later in the chat, because if I say, you'll forget again. Some gastric surgery clips are also there, probably, but I doubt it. It was only cholecystectomy. Okay. So Dr. Sami, your first case. Yeah. Go for it.
Okay, so this is a frontal chest radiograph of an skeletally immature patient. I can see that there is a portacath in place, and the lung fields show some increased vascular markings. However, there is no definite focal lung abnormality. Costopharyngeal recesses and cardiomediastinal shadow are normal. Reviewing the bony structures, I cannot clearly see the right humeral head or the right, and there is a kind of altered texture of the glenoid process of the right scapula. So I'm suspecting that this is a case of known case of aggressive bony lesion involving the right scapula in this young patient with and
there's no known history of bony lesion in this patient. This patient has a history of neuroblastoma.
Neuroblastoma. So so this patient is under chemotherapy, and I'm not appreciating in these images any focal osseous lesion.
What would you do?
So I will compare with the previous images and correlate with the clinical history of the patient.
There are no previous images available.
So I will correlate with the clinical history of the patient, why the patient is...
The patient is a known, he has a known history of operated neuroblastoma for which he's receiving chemotherapy.
So in these images, I cannot appreciate any metastatic deposits. So I will request further assessment by contrast enhanced CT scan of the chest.
What are you worried about? Why would this patient need the CT?
I would definitely, I need to check the osteomediastinum for any osteomediastinal masses. Maybe
are you seeing any suggestion on this X-ray that you need to evaluate it further?
I'm not sure. Maybe the dorsal spine having some osteolytic changes, and maybe the mid-dorsal, one of the mid-dorsal vertebrae has reduced the height.
So this is a routine screening image. If you say it's normal, they're not going to do anything for it. If you say there's something abnormal in the X-ray, maybe you can suggest that they do something else.
You're right. So I'm suspecting that there is maybe some osseous dorsal spine abnormality here. So really we need to assess this one. If not by CT, it will be by MRI of the dorsal spine.
Okay, MRI lumbosacral spine was done. Can you request for remote control?
Yeah, sure.
Yeah.
I will scroll. I think there's some kind of lag.
No, just figure it out. How much is the lag, and you can calibrate your hand movements based on the lag.
Okay, so this is sagittal T1 and T2 weighted images of the lumbar and lower dorsal vertebrae. There is a partial collapse of the L2 vertebral body with the sagging of the posterior cortex encroaching on the spinal canal. This is highly suggestive of marrow infiltration. There are diffuse alteration of the marrow signal of the lumbar spine with the markedly reduced signal in the T1 T2 weighted images with corresponding with areas of low T1 and high T2 signal intensity. This is suggestive of diffuse marrow infiltration. This could be secondary to the chemotherapy, especially with the high signal areas of high signal in the T1. However, this collapsed vertebra could be representing marrow infiltration, metastatic disease of L2 vertebrae, or secondary to osteoporotic collapse. There are multiple areas of signal in the T1 weighted image. Yeah, in the contrast enhanced T1 weighted image, FETRA suppressed the images, the areas of low signal in the T1 weighted image, so increased these areas of enhancement. So the overall findings are highly suggestive of widespread osseous metastasis of the neuroblastoma. So the case will be discussed with the oncology team and the oncology MDT.
Next case. This is a 14-year-old male patient who presented with headache, severe headache, recurrent fits.
Okay, so this axial T2 weighted images of a 14-year-old male patient present with recurrent fits and headache. So I will scroll through the images. So there are several abnormalities in these images. There is marked dilatation of the ventricular system, including the supra and the infratentorial ventricles, with dilatation of the with enlargement of the third ventricle recesses, with evidence of transependymal CSF permeation, and there is a heterogeneously enhanced there is an intraventricular mass lesion inseparable from the septum pellucidum within the right lateral ventricle. The lesion has markedly heterogeneous signal intensity with dark T2 signal and areas of cystic changes. I need to review the rest of the sequences, including the contrast enhanced images.
I'll just scroll because there's a thin section.
Yeah,
Might
really
not scroll well with yeah.
So the mass is heterogeneously enhancing. So in this young age, I would consider the choroid plexus lesion, choroid plexus carcinoma. Other diagnostic possibilities would be intraventricular ependymoma, but the choroid plexus will be more likely because of the associated hydrocephalus, because of the overproduction of the CSF. Ependymoma is the second differential diagnosis. In other age group, in older age group, central
in this age group, I want more, central neurocytoma. How old should the patient be?
Older age group. And the subependymoma also older age group. I'm not sure about the exact age, but this would be the differential diagnosis of the intraventricular masses. So
any other thing coming to your mind? Any other differential?
I'm not sure this is also ependymal enhancement or this is just because of the thin sections.
Yeah, you can ignore that. I just want the differential for the mass.
So choroid plexus lesion, central and even subependymoma, ependymoma, and central neurocytoma. This is not the appearance of the subependymal giant astrocytoma. There is no, the stigmata of the tuberous sclerosis is not seen. So the subependymal giant astrocytoma is not in the list. This all the differential which I can think about.
Sega be seen without tuberous sclerosis?
Actually, it develops as an overgrowth of one of the tubers. So it should I mean the stigmata of the tuberous sclerosis should be there.
Right. So what's your main differential in this case?
The choroid plexus lesion and the ependymoma.
Okay, so a CT was also done for this patient. Can you just take a look and see if it adds anything?
So this non-enhanced CT scan, the lesion is hyperdense. There is no calcifications. Still, we have some areas of breaking down, which was obvious in the CT. And this calcification is peripheral calcification. We have peripheral calcification here, peripheral calcific focus here. So I'm thinking more about in the line of the choroid plexus lesion.
Okay.
Hello?
Yeah, I'm here. So this is your next case. 35-year-old female patient with pelvic pain and tenderness.
Hello?
You can't hear me? Hello? Hi, Dr.
Yeah?
You can hear me, right?
Right now, yes, but I think I lost your voice in the...
Sure. So did you get the
So-
history for this patient?
Oh, no.
35-year-old female patient with pelvic pain and tenderness.
Pelvic pain and sorry, what?
Tenderness.
Tenderness. Okay.
Yeah.
So contrast enhances CT scan of the abdomen and pelvis in the portovenous phase of a female patient present with pelvic pain and tenderness. I'm scrolling from head to toe direction. There's oral contrast also given. Okay, so there are multiple multilocular cystic lesions in the pelvis seen on both sides of the uterus, having thick enhancing walls and associated with stranding of the pelvic fat planes. I'll check for any free fluid. There is no free fluid. If this patient is present with pelvic pain and tenderness, these findings are suggestive of pelvic inflammatory disease with bilateral tube ovarian abscess. I would correlate if the patient has fever or sexually
The patient
active.
does have fever.
And if she is sexually active, or so the possibility of bilateral tube ovarian abscess is considered in this case. I will discuss the findings with the referring physician.
And next case, also abdominal pain. Just one sec. Yeah, go ahead and scroll.
So this is again contrast enhanced CT scan of the abdominal pelvis in the portovenous phase. The patient is present with abdominal pain. So the hallmark of examination so far is the presence of a large heterogeneously enhancing retroperitoneal mass, which is seen encasing the abdominal aorta and the inferior vena cava. Or the actual inferior vena cava is displaced right anterolaterally. The lesion is markedly attenuating of the abdominal aorta, however, still patent. The lesion is seen also involving the right renal artery with subsequent segmental infarction of the right kidney. The lesion is extending from the level of, anyway, the lesion is extending from the level of the renal hilum down to the level of the aortic bifurcation. The other organs are unremarkable or normal, the pancreas in particularly.
Time is over.
There's another mass, but I'm sorry it's jumping, but I think there's another mass here in the left hypochondrium.
Not too concerned about that for now.
Okay,
Just,
so this retroperitoneal mass.
Go to the.
This mass could represent with heterogeneous enhancement with the vascular encasement. So this could be a case of lymphoma or which could be primary or secondary. I mean, lymphomatous mass, secondary lymphomatous mass. So the case will be discussed in the respected MDT and request tissue diagnosis for further assessment. Maybe also require if the case came as lymphoma, so further assessment by PET CT would be required.
Any other differential?
For this one, could be a retroperitoneal lymphadenopathy secondary to TB, or maybe metastatic from testicular neoplasm.
Is there a testicular neoplasm in this patient?
Jumping. some there's hypodense lesion here in the right hemiscrotum. So I will also, one of the workup of this case would be ultrasound of the scrotal ultrasound.
Okay, Dr. Sam. We'll go to the discussion.
Yes.
So the first case. Actually, I thought you would focus more on this lesion because this is the main pathology over here. There is like, you can see the glenoid, the margins are almost completely lost over here, and there appears to be an expansile lesion. I think this was missed, and it was caught on follow-up. No, you told that. You told that. I'm saying in routine practice, in our routine practice, it was just a screening film. It was missed. Anyway, when it came for follow-up, it was more clearly seen, and there is like, I think this is 1 month later follow-up or 2 months later. So there was a destructive lesion over here. This was metastasis, and there was suspicion of a dorsal vertebral collapse over here. So MRI dorsal-lumbar spine was done in this patient. The findings were more striking in the lumbar spine, so I'm just showing you the lumbar spine. Okay, so there are multiple rounded T2 hyper, T1 hypo, and showing post-contrast enhancement lesions scattered in all of the vertebral bodies. There's also collapse. This is most likely a metastatic collapse, like you said. So the second case, I agree there's overproduction of the CSF, and generally if an obstructive lesion in the foramen of Monro or something, it should just dilate the supratentorial ventricular system. But if you see, there's another lesion over here.
Oh, so
Yeah,
we are in the line of germinomas and
No. So yeah, just so foramen of Monro mass in a young patient, the differential what you said is correct, and even central neurocytoma is in the differential in this case. Okay, we did this CT on the same day for this patient, and we noticed this is actually on the contralateral foramen of Monro. Okay, and there's another calcification here. There's another calcification here, tiny calcifications. Okay, so we went back and we reviewed the T2 for this patient, T2 flare. So here you see these hyperintense lines. Yeah, so this is not the sulci. The sulci is going outside, right? And the more you see, the more you'll find in the periventricular regions here. I'm not sure if it's projecting too well here. So these are all radial bands, and the other lesions that we saw were calcified hematomas. And once there was resolution of the hydrocephalus, they put a drain tube in, they did biopsy this lesion. The lesion turned out to be SEGA. Eventually, we did also see cortical tubers in this patient. So this was a case of tuber sclerosis. It was undiagnosed until the patient was 14 years old. Actually, we went back and reviewed an MRI of this patient when he was 7 years old, and the radial bands were missed on that MRI. So yeah, foramen of Monro, always think of SEGA in the first, especially in the exam setting. Young patient, put SEGA, look hard for tuberous sclerosis. You should be familiar with all the stigmata. So you can't just say, there are no other stigmata that I'm seeing. You should say that I'm not seeing any other lesions along the ventricular surface. I'm trying to look for any radial bands, cortical tubers. And when you say it, spell it out, the examiner might also, point you in the right direction. What about this over here? What do you think this is? So, yeah.
Dr. Wasif, could you please point out the radial bands again? Sorry.
Sure, no issues. So here, the hyperintense structure that you're seeing, This is a radial band. This is not the sulcus. I think it's better seen on the T2. Just one second. So here you have the sulcus, and then adjacent to it you have the radial band. Okay, and as we go lower, it's quite subtle, and here.
Okay.
Okay.
Thank you.
So radial bands, basically, we don't know why they form, but the patients have some neuronal migration abnormalities, tuberous sclerosis patients. So they have disorganized structure of the cortex, which leads to the formation of tumors. Tumors are also basically hematomas. They are normal cells organized in a normal way. So you have cortical tumors, and then you have subependymoid tumors, and in between them you have these radial bands. And the hematomas sometimes can keep growing, especially in the foramen of Monro, and they have proliferation of astrocytes. That is when they become SEGAs. Here, there's no malignant potential for SEGA. You have to remember that these are not malignant lesions. They are benign grade 1 lesions, but they cause symptoms like obstructive hydrocephalus. And the second lesion which this patient had was a pineal cyst, which was also causing obstruction. Yeah, there's definitely ballooning of the fourth ventricle also. So I guess there was some overproduction of the CSF by this lesion. So even our first line was thought was like you, Dr. Sami, we gave the same differentials, but once we got that on the CT, we went for tuberous sclerosis.
Mm-hmm.
This was a straightforward case. Sorry. Yeah. Yeah, just dilated fallopian tubes, enhancement, some ascitic fluid, fever, inflammatory markers. So these are all characteristic tuber-ovarian abscess. Sometimes candidates confuse it as multicystic Edlinger lesions, and they tell the differential in that line. So that's why I just showed it.
Okay. Thank you, Dr.
We have one more case. Yeah.
Me?
So the last case, yeah. This was a lymph nodal mass, conglomerated lymph nodal mass, perfectly described. There's encasement of the right renal artery, and you said right renal infarction. This is just ischemia. It's not completely infarcted. So you have to first describe the finding, which is lymphadenopathy, and then you have to give the etiology for that finding, or the differential. So lymphadenopathy can be due to lymphoma, can be infectious due to TB, can be metastatic, and in a male patient, most commonly metastatic, we'll think of testicular tumors. This is a young patient, and I guess you were in a rush, so you just ignored it. I mean, the description of the testis. There's only one testis here. So
okay.
This was an operated malignant germ cell tumor of the testis.
Mm-hmm.
And he had this recurrent metastasis.
Okay. Thank you, Dr.
Okay.
Thank you.
You're welcome. A differential for which case, actually? Candidate 2?
No, that was the brain case. You already discussed that. Thank you.
All right. So candidate 5?
Yes, sir.
Dr. Yasser, is it?
Yes, sir.
I'm glad you are energetic because I'm almost out of energy.
I think so. Every Islamabad orthopedic guy is awake at this moment. So just
every who? Every orthopedic guy.
No, Islamabad orthopedic guy. Islamabad orthopedic. Everybody's awake.
It's quite something happening in Islamabad, Rawalpindi. That's why.
Yeah.
What is it? What is it?
Political.
Political.
Okay.
Yeah, something.
Political.
Everybody's awake. Yes.
I hope it doesn't turn into anything sinister. I hope it passes away. Okay.
Yeah, it already has, but we have to concentrate on the cases again.
Great spirit. All right. So this is a case of a 35-year-old male patient who presented with pinpoint pupils and seizures. You want to request remote control?
Yeah, sure.
All right. Let's see how you manage to scroll.
Okay. So this is I'm given with a 35-year-old male patient MR, pinpoint pupil and seizures.
Yeah, pinpoint pupil and seizures. So take back the control.
I'm just trying to scroll through the images. I'll have an initial look at the MRI. And then I'm gonna come back and sum up my findings.
Okay, you have a scroll wheel on your mouse, or?
Yeah, I do have, but
Yeah, just scroll.
no, I think so. So the obvious abnormality that I can find is foci of abnormal signal intensity in high right parietal lobe, which appear to be iso-intense on T1 and hyper-intense on T2. Similar signal abnormalities are also seen in the anterior part of posterior part of right frontal lobe.
Right. Any other sequences you would like to see?
T1 contrast enhanced, if I may.
Okay.
So I'm having a look at T1 contrast enhanced images, and I can appreciate few ring enhancing lesions in the left cerebral hemisphere, the right frontal lobe. In fact, both the cerebellum, cerebrum are almost seen studded with multiple ring enhancing lesions. The rings are complete and they're not interrupted. There is no definite surrounding logogenic edema or mass effect around these rings. So, though the differential for ring enhancing lesion is wide, but I would keep it narrow, considering no surrounding vasogenic edema or mass effect. My top differential would be neurocystic psychosis, followed by multiple sclerosis. And I would like to communicate these findings to the reference physician.
So how would you narrow down the differential? There is some more clinical history in this patient. Actually, the patient was also complaining of swelling in the left preauricular region.
Preauricular region.
Yeah, the preauricular.
Yeah. Swelling in the preauricular region would most likely be secondary to some lymph node enlargement and right preauricular region. I cannot
left.
Yeah. I can appreciate some enhancing mass lesion in the internal air, left internal air, but I'm not.
Let me just show you.
Yeah, okay.
What do you think about this?
Sir, I'm not able to see you now.
Now?
Yeah.
So what do you think about this?
Comparing it to the other side, this is also ring enhancing lesion.
And where is it?
It is in the musculature of probably lateral pterygoid muscle.
It's the left masseter muscle, but anyway, so what do you think of the diagnosis?
Sir, if the ring enhancing lesions are there in the muscles and brain as well, so probably parasitic infestation is more likely. Neurocystic psychosis would be at the top of a differential then.
Okay. So this is a youngish female patient presented with gross abdominal distension and pelvic pain.
So young female patient with gross abdominal distension and limping.
Pelvic pain.
Pelvic pain. So, sir, the immediate abnormality that I can appreciate in this X-ray of the abdominality view is a well-defined pear-shaped, loosened fat density lesion in the right hemipelvis, which is well circumscribed and demarcated. And there is no associated surrounding calcification seen around it. Rest of the bones of the pelvis are normal. The vertebra of the lumbar spine, they also appear to be normal. The cross shadows, they appear to be normal. No definite abnormal bulbous shadows are seen. No organomegaly can be appreciated. So to sum up, I would like to keep a differential of metastasis syndrome or adenoid cyst in the right hemipelvis as my differential. I'd like to proceed on with this case. I'd like to get a CT scan done for this case, or I'd like to get an MR of the pelvis done for this case in order to confirm my finding.
Fine. We did a CT actually.
Yeah.
So does it confirm your findings?
Yeah, there is a large heterogeneous cystic mass with internal calcification seen in the center of originating from the right adnexal region extending into the abdomen. These findings are quite consistent with mature cystic teratoma. However, keeping in view the size of this lesion, which is apparently is more than 10 centimeters, I would also have high suspicion for any malignant changes. However, I cannot see any internal septation or nodularity or a polyflash form shape of this mass. I'd like to, in order to confer
anything else you're concerned about?
Yes, sir. These findings, this mass predisposes to ovarian torsion, and
so this is your next case. Again, a youngish 40-year-old male patient who presented with lower back pain.
Yeah, I'm presented with a youngish female patient with lower back pain. Male patient with lower back pain. I am provided with MRI of lumbar spine. I can appreciate that there is some marrow signal change seen in along the inferior plate of LV4. The vertebral heights, they appear to be relatively preserved. Though there are desicatory changes seen at LV3, LV4, and LV4, LV5 vertebral bodies. No, the marrow signal change at the inferior plate of LV4 It doesn't show any change on T2 it sequences. I'm having a look at the rest of the scan to find any other abnormality. So there appears to be some elevation of the posterior spinous ligament in this region. This just adjacent to this elevation, the area appears to be isotense on T1 and hyperintense on isointense on T1 and hyperintense on T2.
Anything else?
No surrounding cortical end-plate irregularity or abnormal signal intensity to indicate an infective fasciitis is seen in the L4, L5 disc. To sum up, this just appears to be grade moderate 3 change of the spine with desicatory change. Probably this is contributing to the back pain or the backache.
Mm-hmm. So how would we manage this patient?
I'll convey my findings to the treating physician. However, at this section, there appears to be diffuse loss of narrow signal in the L5 photograph. I would be suspicious for some infiltrative disease of the marrow. Can I know the age of this patient? Young patient?
35.
Oh, I will not be concerned about myeloma in this age. If there is any known primary that
no known primary.
Probably said
he's a rural patient who has just come to the hospital in the city for this checkup because the back pain is worsening. So will you do anything else for this patient? Anything you're concerned about?
That I'm having a look at. This area at L4, L5 level, it is actually causing obliteration of intervertebral neural foramen. And
so what can we do to further elucidate what it is?
Sir, if I can have some axial sections to see.
Which axial would you like?
T2.
Mm-hmm. So just a second, I'll take you to that level because I think I turned off.
Yes, sir. The bar.
Here you go.
Yes, sir. I can appreciate that there is complete obliteration of the left neural foramina, and along with the desiccated chain, this appears to be a left neural foramina disc protrusion, which is causing complete obliteration. I'd like to convey these findings to the neuro reference physician, and I'll ask him to correlate them clinically if there is corresponding nerve root involvement in them.
Okay. This next case is a RTA, and the patient is desaturating, and they have managed to stabilize the patient with great difficulty.
Okay, so the patient of RTA is desaturating and managing to keep the saturation with great difficulty. The first thing I'll be concerned about is there is an acute hemorrhage going on. abdomen. The gross abdominality that I can see is moderate to gross abdominal pelvic tightly. In this contrast now, CT scan abdomen.
Time is over.
There is an area of mottled air attenuation deficiencies seen just adjacent to the liver. Probably that is features in the hepatic structure. I'll try to look for an area of acute extravasation of contrast.
I think I'll just scroll because
Yep.
the time is already out. We'll just get to the diagnosis first.
Yep. I actually saw some contrast extravasating from the right side. Yeah, this side. Yeah, this side. Yeah. So this external ionic artery, probably there's some contrast extravasating from this space into the peritoneum, and probably this is the cause of acute hemorrhage and destabilization of patient. There is active extravasation of blood going on at this place. I'll convey my findings to the reference physician in order to refer the case to the interventional radiologist to control the space.
All right, fine. We'll go to the discussion.
And on that MRI, it's just that flashback. I saw some small abscesses just in the perivertebral area. Afterwards,
When you saw on
just in the nick of
CT.
just in the nick of time, I was scrolling through both the cases at the same time in my brain.
Yeah, sure. So you started off, I think, with flare, right? Or was it T2? T1 and T2, right?
No, it was T1 and T2.
Yeah, so T1 and T2. So when you started off, you said there is hyperintensity.
Yep.
Scattered hyperintensity, right? So what does this hyperintensity represent?
Is edema.
And then when you were describing the post-contrast images, you said there's no associated edema or mass effect. So just
negated my own finding.
Yeah. So there are multiple ring-enhancing lesions. You're right. This is neurocystic sarcosis, and this is quite characteristic of neurocystic sarcosis. Are you aware of the different stages of neurocystic sarcosis?
There are 3 stages. I used to remember.
Okay. Right. So no problem.
And
so
at
there
the
are 4
end stage,
stages.
They calcify everything. Calcifies.
Yeah. So there are 4 stages. Just I'll take back the remote control because I think by mistake you're taking it.
Yeah, I'll leave it.
So we'll just go over the stages quickly because we are seeing all the stages over here. In the first stage, the parasite. What is the parasite in this thing? Neurocystic sarcosis. What is the name of the parasite? Yeah, you have to remember this. Tinea solium. I didn't ask you, but in the exam they'll ask you. Yeah. Tapeworm. Okay. So the parasite is living peacefully in the brain. It's just living its life. It's not doing anything. So you can see over here, there's a small cystic lesion, which is hyper on T2, hypo on T1. It generally does not show any enhancement at this stage. Okay. It's quietly living its life. And it can live up to 4 or 5 years. We have another lesion here, which is not showing any edema, not showing any enhancement. But if you give some treatment, maybe you can shorten its lifespan. Within 1 or 2 years, it will die. So this is the vesicular stage. This is clean fluid, almost CSF intensity. On FAIR, it will show suppression. It will be just CSF fluid. Okay. Once it dies, however, now the problems start to happen. First of all, the fluid within the cyst, it becomes proteinaceous. It becomes murky. It is called colloid. Okay. So when the fluid becomes colloid, it starts to become slightly hyperintense on T1. Okay, it doesn't suppress as much on flare. I didn't put flare, and it starts to show like intense ring enhancement. Okay, it also starts to have this surrounding edema because the wall of the cyst is no longer intact. Once the parasite within it is dead, it starts to become leaky. So you have this intense edema, you have contrast enhancement, and you have T1 hyperintensity. And sometimes, in the post contrast, you I don't know whether this is innate T1 hyperintensity or there's something enhancing, but you call a nodule within a cyst a target sign, which is also a sign of neurocystic cirrhosis. Okay, so this is the second stage, which is a colloid vesicular stage. And then the organism is dead. So obviously, it will start to retract. The lesion itself will start to retract, and it starts to undergo granulation. Okay, so you see over here, there's a retraction. It is still hyper intense, but the edema is becoming less and less with these lesions. Eventually, like you said, the first stage is calcified nodular stage. So calcifications we can see on MR, but the easier thing would be to do a CT. So you'll see these scattered calcifications. Okay. Another thing is like if it's involving the musculature, then the diagnosis becomes almost certain for neurocystic cirrhosis. You said multiple sclerosis. I wouldn't put multiple sclerosis in the differential. The differential would be neurocystic cirrhosis, tuberculomas, maybe toxoplasmosis. The next case was this. So pelvic pain, expect this case in the exam, and you have to pay attention to these calcifications. There's a nice molar tooth over here, there's a canine tooth over here. Okay, maybe this is fat, maybe this is gas, but they are definitely calcifications. Second thing you need to pay attention on an abdominal film is paucity of gas. So there's no gas over here. A large area where we are not seeing any gas means that there is a mass lesion which is displacing the bowel loops. So that's it. That's kind of the spotter. So there's almost a jaw which has formed over here in this patient. You can see the molar, canine, rabbit incisors. A complete mandible has formed over here, hemimandible at least. A mature teratoma does not undergo malignant transformation, as far as I know. Immature teratomas will undergo malignant transformation, or maybe they will undergo malignant transformation, but it's extremely rare for mature teratomas to undergo malignant transformation. They have become what they wanted to become. Now they won't become malignant. You know what I mean? Immature, they're uncertain. They might become a complete teratoma, or they might undergo some malignant transformation and become some cystic adenocarcinoma or something like that. So once you see hair, fat, from all three endodermal layers, then it's already a mature teratoma or a mature dermoid. So very less possibility of malignant transformation. However, very high possibility of torsion. So what would be more concerning over here is torsion. In fact, you have to rule out torsion whenever you see a dermoid. You have to evaluate the vascular to make sure there are no twists, enhancement, fat, sanding. So these are the things that you should always look for when you see a dermoid. I think, yeah, that's good. So this case of the lumbar spine, you took a very long time looking at the posterior spinal ligament. You didn't pay any attention to the anterior spinal ligament, and there is hyperintensity T1, right? This is edema. So I would have been happier if you would have said Modic type 1, hyper. Maybe over here you got confused. But overall, just If you had noticed this, I think you'd have got it. What I wanted you to
Hmm.
say was, I want to see post-contrast images. So on the post-contrast images, it's much more obvious. There is paravertebral abscess spondylitis, which is extending into the intervertebral space, intervertebral foramen. And at the moment, there's no compromise of the spinal canal itself, but the nerve might be impinged in this area. Rather than saying LV, say lumbar. Okay, because that is the more common term. I mean, with us, you can say anything, but the fourth lumbar vertebrae or the third lumbar vertebrae. So that would be a better way. What do you think the organism is in this case?
Tuberculosis.
Why tuberculosis?
Because there is anterior subligamentous extension, anterior and posterior subligamentous extension with the paravertebral small abscesses. With common.
Yeah, but generally, if there is psoas abscess and there's spread over multiple levels, then that would make the diagnosis more favorable towards tuberculosis. Any differential you can think of? I said this is a little patient.
Or the other will be just infective vasculitis.
He's a shepherd. He's a shepherd. So it can also be brucellosis. Yeah.
Okay.
Yeah. This case, where's the external iliac artery? The external iliac artery is down over here. This is one of the branches of the superior mesenteric artery. If not, yeah, it's one of the branches of superior mesenteric artery. So this signifies a mesenteric tear. There's extravasation of contrast, active extravasation, and when you say ascites, yeah,
it was very near to that external iliac artery that just took a while there.
Yeah, so this is the external iliac artery. Right?
No, this is the internal.
Oh, sorry. This is the internal iliac artery. My bad. So this is the external iliac artery, and this is completely in the mesentery. So this signifies a mesenteric tear. So that is the emergency. So this does not have any management with interventional radiology. This goes directly to surgery and surgical management. They did like jejunal resection, anastomosis for this case. There were two large mesenteric tears. When you say ascites, you're already thinking of internal hemorrhage in this patient. Just say dense ascites. Okay.
Yeah.
And you have to speak in continuation. So in arterial, there is blush, and venous, there is continued increase in the size of the blush. And then I would also, ask for the delayed in this case, and delayed, it becomes much more obvious. And this is all extravasated contrast now that we have, which we are beginning to see as layered. So they took this patient directly from the CT room to the operation theater, and luckily they saved his life. So,
thank you very much.
Dr. Wasif, can you please point out again how is this the branch of superior mesenteric?
Sure. So if you just follow the superior mesenteric artery, it's going this side, right? And then you have certain branches. This is a branch, this is a branch. And I was tracing the wrong branch, but the anterior branch, and there's a blush. You don't necessarily have to trace the complete artery, but all of these are superior mesenteric artery branches. Basically, this is a mesenteric tear. Why would you have hemorrhage from an external iliac artery? What would penetrate it? What would cause to disrupt it? So for branches of superior mesenteric artery, if you have a mesenteric tear, that can lead to hemorrhage.
Yeah. Okay.
Okay. Thank you.
You're welcome. So I think I've come to the end of the session. I'll just go through the.
Yes, thank you so much, Dr. Wasif. There are a few questions, I believe, in the chat box for you to answer.
Yeah, I'm just going through it. So diagnosis of the last case, I don't know which case that was. So can we give the differential of undescended testis in this case? Neoplasm and undescended testis, it won't be so high. I don't agree with undescended testes. It would be, if it were a little lower, probably paravesical or near the aortic bifurcation, I would still, say, okay, it could be an undescended testis, but you have to go with most common first. It's lymphadenopathy. And suppose you don't have the history of operated testis and you're only seeing one testis, then maybe you can raise that possibility. But more likely would be a previous operated tumor in the testis. Okay, CT. Yep. Can we have? Thank you so much. Malignancy of dermoid. Like I said, the potential of malignancy in a mature dermoid cyst is very low. I don't know what the signs of malignancy are, but it almost doesn't happen. It's only in immature teratoma that we see malignant transformation. brucellosis, and TB. There isn't a lot to differentiate. The history can help you. And brucellosis, generally, there's no fever. It only involves a single level. It has not caused the classic psoas abscess, and the subligamentous spread to multiple levels. So TB would also eventually cause a destruction of the vertebral bodies itself and collapse. But yeah, history would be your guiding factor. If the patient is like an intravenous drug abuser, bacterial versus TB would be most likely. If the patient is coming from a farming background, then brucellosis can be raised. Most welcome, Dr. Sabahat. AVMK suprahilar metallic dots. So those were vascular closure devices. I should have actually made them more clear. They were vascular. Basically, they had some fan-shaped septae in the middle, and kind of devices which are used to close patent ductus arteriosus. If you look for those devices, you'll be able to see them. Thank you, Supriya. Yeah, subligamentous is more in favor of TB. Delayed 5 minutes, 3 to 5 minutes. Not more than that. The patient needs to be taken to the OT room. All right.
Yes, wonderful.
Okay.
Dr. Wasif, thank you so much for your time. I know it's
Most
quite
welcome.
late over there in
Not
Kuwait
at all.
as well.
Not at all. Not as late as in the subcontinent. So thank you all for attending. I'll just be
thank you,
sharing
everybody.
a evaluation form in the group. I would be thankful if everyone took a minute and just filled it out.
Did you share it?
I didn't share it yet. I'll share it now.
Yeah, you can share it.
Oh, okay. Thank you so
You can
much.
share
Have a
it in
good
the
night,
group.
everyone.
Yeah. Thank you so much, everybody. Thank you. Take care.